Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to this solid anatomy lecture on the thigh. So we're going to talk about the compartments of the thigh, an overview of the hip and the knee joint. Now you're going to find a discussion on the femur bone and its features in the lecture on the gluteal region. Now I'll be back later for some clinical correlations and the end of session quiz. But for now, I'm going to turn it over to our primary lecturer, Dr. John Phelan.
You may recall from the solid anatomy introductory lections that the superficial fascia of the body is the loose connective tissue layer that has the subcutaneous fat running through it. The deep fascia, meanwhile, consists of rigid, fat-free sheets of connective tissue whose collagen fibers are organized into densely packed parallel bundles that give it notable tensile strength. The deep fascia of the lower extremity is exceptionally dense and inelastic, and is usually described in textbooks as fitting tightly over the muscles like a stocking. It is continuous from the inguinal ligament to the foot, but it is named differently according to the region it covers. For instance, the deep fascia is called the fascia lata, where it covers the thigh, but it is called the crural fascia below the knee, where it covers the leg. The fascia lata is found at the same level as Scarpa's fascia in the lower part of the anterior abdominal wall. However, these two layers are not continuous with each other because they both fuse to the inguinal ligament. You can demonstrate this relationship if you are dissecting a cadaver in conjunction with your anatomy course. If you place your hand under the fascia lata over the anterior thigh and move your hand superiorly toward the abdomen, you will be stopped at the proximal end of the thigh by the inguinal ligament. The fascia lata dives into the thigh and forms three intermuscular septae that attach to the linea aspera. These septae divide the thigh into anterior, middle, and posterior compartments. Each compartment of the thigh gets its own motor nerve. Two come from the lumbar plexus. The other originates from the sacral plexus. The lumbar plexus was described in the solid anatomy lecture on the posterior abdominal wall. Briefly, this plexus is formed by the ventral rami of the first four lumbar spinal nerves. The ventral rami of L2, L3, and L4 split into ventral and dorsal divisions. The ventral divisions unite to form the obturator nerve, which descends into the pelvis and passes through the obturator canal, a tunnel through, in order from medial to lateral, the obturator internus, the obturator membrane, and the obturator externus. The obturator nerve provides motor innervation to the obturator externus, but not to the obturator internus. The obturator nerve then enters the medial compartment of the thigh. The dorsal divisions of the ventral rami of L2, 3, and 4 join to form the femoral nerve, which runs inferiorly between the iliacus and psoas major muscles, then passes deep to the inguinal ligament to enter the anterior compartment of the thigh. The motor nerve of the posterior compartment, the sciatic nerve, arises from the sacral plexus, which was described in the solid anatomy lecture on the gluteal region and the hip joint. The largest branch of the sacral plexus is the sciatic nerve, which is actually two nerves that are bound together in a sheath of connective tissue. While they are bound together, these two nerves, the tibial nerve and the common fibular nerve, are usually referred to as the tibial division of the sciatic nerve and the common fibular division of the sciatic nerve. When the sciatic nerve physically divides, usually as it approaches the back of the knee, the resulting branches are at that point called the tibial nerve and the common fibular nerve. Clinically, the common fibular division is most often referred to as the common peroneal division. So we'll be calling it the common peroneal division for the rest of the lecture. Peron and fibula both refer to the non-weight-bearing bone of the leg. The only difference is that peron is Greek and fibula is Latin. Be aware, however, that most textbooks and atlases use the term fibular in place of peroneal. Just remember that anytime you see the word fibular while you're reading, whether it's referring to a nerve, a muscle, or a blood vessel, you can replace it with peroneal. The tibial division of the sciatic nerve is composed of the ventral divisions of L4 to S3, while the common peroneal division carries contributions from the dorsal divisions of L4 to S2. Like most branches of the sacral plexus, the sciatic nerve leaves the pelvis through the greater sciatic foramen and emerges in the gluteal region deep to the gluteus maximus at the inferior edge of the piriformis. It travels inferiorly, crossing the surfaces of the superior gemellus, the obturator internus tendon, the inferior gemellus, and the quadratus femoris, and dives into the posterior compartment of the thigh. The sciatic nerve does not give off any branches in the gluteal region. Next, we're going to describe the muscles that occupy each compartment of the thigh. Since these muscles are acting on the hip joint and the knee joint, we'll start with a brief overview of these joints, which are covered in greater detail in the Solid Anatomy lecture on the gluteal region and the hip joint, and the Solid Anatomy lecture on the knee. The hip joint, an articulation between the head of the femur and the acetabulum of the hip bone, is a very stable synovial, ball and socket joint. It is a multi-axial joint that allows 6 actions. Flexion of the hip joint causes a decrease in the angle between the anterior surface of the thigh and the trunk of the body. Extension increases this angle. Abduction of the femur at the hip joint, often stated more simply as abduction of the hip joint, involves moving the femur away from the midline of the body. Adduction of the femur at the hip joint brings the femur toward the midline of the body. The femur may also be rotated at the hip joint. Lateral rotation of the femur at the hip joint involves rotating the femur away from the midline, while medial rotation of the femur at the hip joint involves rotating the femur toward the midline of the body. Clinically, these actions are often referred to as external rotation instead of lateral rotation, and internal rotation instead of medial rotation. The knee joint, specifically the tibiofemoral joint, is an articulation between the convex medial and lateral femoral condyles and the rather flat medial and lateral tibial condyles. It is a synovial hinge-type joint. The knee is usually considered to be a uniaxial joint that is capable of flexion and extension, but some rotation about the knee joint also occurs. The posterior compartment of the thigh is occupied by the 3 hamstring muscles, 4 if you count the heads of the biceps separately, and a portion of one of the adductor muscles. The term hamstring seems to have originated centuries ago when butchers would hang pigs upside down outside their shops to attract customers. They found it convenient to do so by inserting a hook between the femur and the distal tendons of the muscles of the posterior compartment of the thighs, or hams, as these tendons cross the knee to insert on the bones of the legs, or shanks. The butchers noted that these tendons had the consistency of thick strings and named them accordingly. Thus, a hamstring muscle is an occupant of the posterior compartment of the thigh that crosses the knee. 3 hamstring muscles take their origin from the ischial tuberosity. The semitendinosus, named for its long insertion tendon, runs inferomedially from the tuberosity and inserts on the medial aspect of the proximal tibia. Deep to the semitendinosus is the semimembranosus, which has a broad, flat tendon of origin that might be described as membranous. The semimembranosus attaches to the posterior part of the medial tibial condyle. Running inferolaterally from the ischial tuberosity is the long head of the biceps femoris. It merges distally with the short head of the biceps femoris, which originates from the linea aspera on the posterior side of the shaft of the femur. The single insertion tendon of the biceps femoris attaches to the head of the fibula. The fifth muscle that is usually considered part of the posterior compartment is the ischiocondylar portion of the adductor magnus muscle. The adductor magnus originates from the ischial tuberosity and the ischiopubic ramus. At the distal end of the muscle is a gap, the adductor hiatus, that transmits the femoral vessels. The hiatus also separates the broad insertion tendon of the adductor magnus. Medial to the hiatus, the muscle inserts along the linea aspera, while lateral to the hiatus, there is a thick, narrow tendon that inserts on the adductor tubercle. The portion of the adductor magnus that originates on the ischiopubic ramus and inserts on the linea aspera is called the pubofemoral or adductor portion of the muscle. It is considered to be part of the medial compartment of the thigh, since it is innervated by the nerve of the medial compartment, the obturator nerve, and it adducts at the hip joint like the other muscles in the medial compartment. The portion of the adductor magnus muscle that originates on the ischial tuberosity and inserts on the adductor tubercle is called the ischiocondylar or hamstring part. It is considered to be a member of the posterior compartment because its origin, innervation, and action are the same as the long muscles of this compartment. To complicate matters further, however, note that the hamstring part of the adductor magnus is not really a hamstring muscle because its insertion tendon does not cross the knee, which is one of the qualifications necessary for a hamstring muscle. So we'll just refer to it as the ischiocondylar portion of the adductor magnus. Let's summarize the actions and innervation of the muscles of the posterior compartment. Consider that there are 5 muscles in this compartment when the heads of the biceps are considered separately. 4 of the 5 muscles cross the hip joint and are extensors of the hip joint. They are the ischiocondylar part of the adductor magnus, the semitendinosus, the semimembranosus, and the long head of the biceps femoris. Only the short head of the biceps does not extend the hip. 4 of the 5 muscles cross the knee and are flexors of the knee joint. They are the semimembranosus, the semitendinosus, and the long and short heads of the biceps femoris. The ischiocondylar portion of the adductor magnus does not flex the knee. All 5 muscles in the posterior compartment of the thigh are innervated by the sciatic nerve. The short head of the biceps is innervated by the common peroneal division of the sciatic nerve, while the semitendinosus, semimembranosus, long head of the biceps femoris, and the ischiocondylar part of the adductor magnus is innervated by the tibial division of the sciatic nerve. The medial compartment of the thigh contains 4 muscles. The gracilis is named after the Latin word for slender, which is an accurate assessment of its thickness. It is a long, strap-like muscle that originates on the pubis, passes inferiorly along the medial surface of the thigh, and crosses the knee to insert on the medial aspect of the proximal tibia. The remaining 3 muscles in the medial compartment, from superficial to deep, are the overlapping adductor longus, adductor brevis, and adductor magnus. The adductor longus and brevis originate on the pubis and insert on the linea aspera of the thigh. The pubofemoral portion of the adductor magnus originates on the ischiopubic ramus and also inserts on the linea aspera. All four muscles in the medial compartment of the thigh adduct the hip joint. The adductor longus and brevis and the pubofemoral part of the adductor magnus also assist in flexion of the hip joint. The gracilis, the only muscle in the medial compartment that crosses the knee, is a flexor of the knee joint. The gracilis, the adductor longus, the adductor brevis, and the adductor portion of the adductor magnus are innervated by the obturator nerve. Just lateral to the adductor longus lies the pectineus, a muscle in the anterior compartment of the thigh. The pectineus originates on the pecten pubis, the ridge on the superior edge of the superior ramus of the pubis. It inserts on the pectineal line of the femur, which you may recall is the medial extension of the bifurcated linea aspera. Evidently, the person who named this muscle thought it resembled a comb, since that is the Latin translation of its name. The pectineus is a flexor and adductor of the hip joint. Lateral to the pectineus is the iliopsoas muscle, which is a combination of two muscles you may remember from the solid anatomy lecture on the posterior abdominal wall, the iliacus and the psoas major. The iliacus originates in the iliac fossa on the medial side of the ala of the ilium, while the psoas major originates from the bodies and transverse processes of the lumbar vertebrae. These muscles pass deep to the inguinal ligament and merge to form a common insertion tendon that attaches to the lesser trochanter of the femur. The iliopsoas is the strongest flexor of the hip joint. The sartorius is the longest muscle in the body. It originates on the anterior superior iliac spine and inserts on the medial surface of the proximal tibia. You may have noticed that we have now named three muscles that insert on the medial aspect of the proximal tibia: the semitendinosus from the posterior compartment, the gracilis from the medial compartment, and now the sartorius from the anterior compartment. The insertion tendons of these three muscles actually merge to form a structure that bears a vague resemblance to a goose's foot, hence the Latin name pes anserinus. All of the muscles inserting into the pes anserinus flex the knee joint. The main actions of the sartorius can be summarized visually by crossing your leg. It flexes the hip, laterally rotates the femur at the hip joint, and flexes the knee. These actions actually led to the muscle being named the sartorius. Perhaps you've heard the term sartorial splendor used to describe fancy clothing. Sartor is the Latin word for tailor, and sartorial refers to tailoring. Tailors would sit with one leg crossed to provide a surface to place a garment or a piece of fabric they were sewing. And since the three actions they performed in order to cross the leg were the main actions of the sartorius, well, you get the picture. The remaining four muscles in the anterior compartment of the thigh are the members of the quadriceps. They are the rectus femoris and the three vasti muscles, the vastus medialis, the vastus lateralis, and, deep to the rectus femoris, the vastus intermedius. The rectus femoris originates from the anterior inferior iliac spine and is the only quadriceps muscle that crosses the hip joint. The vasti muscles originate from the shaft of the femur. Interestingly, parts of the vastus medialis and vastus lateralis originate on the linea aspera on the posterior side of the shaft and wrap around the lateral and medial sides of the femur. The quadriceps tendon is the common insertion tendon of all four quadriceps muscles. It is attached to the superior margin of the patella, the largest sesamoid bone in the body. You may recall from the Solid Anatomy Introduction lectures that a sesamoid bone is a bone that is embedded in a joint capsule or a tendon. The inferior margin of the patella is attached to the tibial tuberosity on the anterior side of the proximal tibia by the patellar ligament, which is often clinically referred to as the patellar tendon. The quadriceps muscles extend the knee joint. The rectus femoris also flexes the hip joint. Here's a summary statement about the innervation to the muscles of the anterior compartment of the thigh. The vastus lateralis, vastus intermedius, vastus medialis, rectus femoris, and the sartorius are innervated by the femoral nerve. The pectineus is innervated by both the femoral nerve and the obturator nerve. You can remember this by considering that the pectineus is on the border of the medial and anterior compartments. So it is innervated by branches of the nerve of the medial compartment, the obturator nerve, and the nerve of the anterior compartment, the femoral nerve. The iliacus is innervated by the femoral nerve, while the psoas major, which abuts the lumbar intervertebral foramina, is innervated directly by ventral rami of the first three lumbar spinal nerves. Thus, it may be stated that the iliopsoas is innervated by the femoral nerve and the ventral rami of L1, L2, and L3. If you're looking at the anterior side of the thigh in the laboratory, or just looking at an illustration of the thigh, you'll probably notice a muscle forming an angle with the proximal end of the sartorius. That's the tensor fascia lata, which was described in the Solid Anatomy lecture on the gluteal region and the hip joint. It is not considered to be a muscle of the anterior thigh, but instead is associated with muscles of the gluteal region, specifically the gluteus medius and minimus. The blood supply to the thigh may be traced by starting at the aorta. The aorta bifurcates at about the level of the fourth lumbar vertebra, which is at the level of the iliac crests, into the right and left common iliac arteries. Each common iliac artery bifurcates into an internal and an external iliac artery. If you've watched the Solid Anatomy lecture on the pelvic wall, you may recall that the obturator artery usually branches off of the internal iliac within the pelvis and passes through the obturator canal to reach the medial compartment of the thigh. The obturator artery provides some of the blood supply to this compartment. The external iliac artery passes deep to the inguinal ligament, where its name changes to the femoral artery. The femoral artery enters the femoral triangle, which will be described in a moment, and quickly gives off three branches: the superficial iliac circumflex artery and the superficial epigastric artery supply superficial parts of the inferior abdominal wall. The external pudendal artery runs medially to supply the superficial part of the perineum. The femoral artery next gives off a large branch, the profunda femoris artery, or deep artery of the thigh, that dives deep into the anterior compartment of the thigh. The first two branches of the profunda femoris are usually the medial and lateral circumflex femoral arteries, which join to form an anastomotic ring around the proximal end of the shaft of the femur. This ring gives off branches that feed the head and neck of the femur. When you hear about someone breaking their hip, they usually have not broken their hip bone, but rather the neck of their femur. If the arteries traveling along the neck of the femur to the femoral head are ruptured when the bone breaks, the blood supply to the proximal femur is cut off, and that portion of the bone dies, a clinical situation known as avascular necrosis. The remedy for that is replacement of the dead bone with a prosthesis, a procedure commonly referred to as a hip replacement. The lateral circumflex femoral artery also gives off a descending genicular branch, that contributes to the anastomotic circulation around the knee joint. For more information on the genicular arteries, download the Solid Anatomy lecture on the knee. The profunda femoris artery gives off 3 or 4 perforating arteries that pierce the adductor magnus muscle and provide most of the blood supply to the posterior compartment of the thigh. The profunda femoris terminates as the most inferior perforating artery. Remember that while the profunda femoris artery supplies the posterior compartment of the thigh via the perforating arteries, it does not enter this compartment itself. It remains in the anterior compartment. Normally, no artery runs the length of the posterior compartment alongside the sciatic nerve. Both the femoral artery and the profunda femoris artery also give rise to numerous unnamed muscular branches supplying the anterior and medial compartments of the thigh. The deep venous system of the thigh usually mirrors the arterial system, and its branches are named accordingly. The only difference is that the veins are usually multiple and surround the arteries as venae comitantes, which assist in preventing heat loss through the extremities when they are exposed to low temperatures. If you are walking around in cold air, your extremities tend to get cold faster than the core of your body, because the core of the body is usually better insulated with fat and has less surface area than the extremities. Warm blood being pumped from the core of the body is likely to lose that warmth once it reaches the limbs. Instead, the vena comitantes, carrying cold blood back from the extremities, absorb the warmth from the arteries they surround and carry it back to the core before it can be lost through the extremities. The femoral vein becomes the external iliac vein at the underside of the inguinal ligament and passes lateral to the pelvic brim until it joins with the internal iliac vein to form the common iliac vein. The right and left common iliac veins merge at about the level of the 5th lumbar vertebra to form the inferior vena cava. An impressive network of veins running through the superficial fascia drains the skin and fascia of the thigh. This network drains into the deep venous system of the thigh through perforating veins that perforate the fascia lata, or by draining into the great saphenous vein. The great saphenous vein begins at the medial end of the dorsal venous arch of the foot and continues superiorly along the medial side of the leg and the thigh, between the skin and the deep fascia. Just inferior to the inguinal ligament, the great saphenous vein passes through the saphenous opening in the fascia lata to drain into the proximal end of the femoral vein. The great saphenous vein not only receives numerous branches from the superficial venous network of the thigh, but also communicates with the superficial venous network on the anterior abdominal wall through the superficial epigastric vein and the superficial circumflex iliac vein. To get a better idea of how the major nerves and blood vessels of the thigh are positionally related to each other and to the muscles of the thigh, let's end this lecture with a discussion of the femoral triangle and the adductor canal. The base of the femoral triangle is the inguinal ligament, that segment of the external abdominal oblique aponeurosis that stretches from the anterior superior iliac spine to the pubic tubercle. The lateral border of the triangle is the sartorius, while the medial border is the adductor longus. The roof of the femoral triangle is formed by the fascia lata. The pectineus muscle forms the medial half of the floor of the triangle, while the iliopsoas is the lateral half of the floor. If you are having difficulty confirming the identity of the medial circumflex femoral artery while dissecting a cadaver, follow the artery to the floor of the femoral triangle. This artery usually passes right between the pectineus and the iliopsoas. From lateral to medial, the contents of the femoral triangle are the femoral nerve, the femoral artery, the femoral vein, and the inguinal lymph nodes, which are usually palpable. A mnemonic used to remember the order of the contents of the femoral triangle is navel. N for femoral nerve, A for femoral artery, V for femoral vein, and L for the inguinal lymph nodes and their associated lymphatic vessels. The vessels and the lymphatics, but not the nerve, are bound together in the triangle in the femoral sheath. The anterior portion of the femoral sheath is composed of transversalis fascia from the anterior abdominal wall, and the posterior portion of the sheath is composed of the deep fascia of the iliacus muscle on the posterior abdominal wall. The femoral sheath is divided into compartments for the artery, the vein, and the lymphatics. The compartment for the lymphatics, the most medial compartment of the sheath, is called the femoral canal. The femoral canal, which opens into the abdomen superiorly through the femoral ring, is the site of femoral hernias. The femoral artery and femoral vein travel inferomedially through the anterior compartment of the thigh in a tunnel called the adductor canal. The adductor canal begins at the apex of the femoral triangle and ends at the adductor hiatus. The roof of the adductor canal is the sartorius muscle, and the floor is formed by the adductor longus and adductor magnus muscles. Traveling through the adductor canal with the femoral vessels is a branch of the femoral nerve, the saphenous nerve. Unlike the femoral vessels, the saphenous nerve does not pass through the adductor hiatus at the distal end of the canal. Instead, it pierces the deep fascia and runs in the superficial fascia of the leg to innervate skin. The femoral vessels, upon crossing the adductor hiatus, enter the popliteal fossa and experience an exciting name change that will be detailed in the solid anatomy lecture on the knee.
So we're finished with the lecture on the thigh. Before we move into our end of session quiz and the mock practical, I want to discuss femoral hernias since Dr. Failing brought it up in his lecture. Now, a femoral hernia occurs when a portion of the bowel, or something just like fat extending from it, pushes through the femoral ring into the femoral canal, which again is the medial compartment of the femoral sheath within the femoral triangle. Now, a femoral hernia thus forms a bulge inferior to the inguinal ligament and medial to the femoral vein. Now, femoral hernias, which only account for less than 10% of all hernias, are more prevalent in females than in males. And it's thought that this frequency is due to the fact that the female pelvis is wider than the male pelvis. And the resulting greater width of the femoral ring makes it more vulnerable to herniation in female patients. All right, so let's go through a couple questions. Where do femoral hernias occur? It's a herniation through the femoral ring into the femoral canal. Next, what are femoral hernias more common in males or females? Easy, that's females, and that's because the female pelvis is wider, making the femoral ring wider. All right, guys, so let's move on to the end of session quiz. Now, I want you to pause the video and answer the end of session quiz questions, and then we'll go through those answers together. Let's get going. First question. What landmark differentiates the external iliac artery from the femoral artery? That's going to be the inguinal ligament. Next, what is the largest branch of the femoral artery? That's the deep or profunda femoral artery. Next, which arteries supply the head and neck of the femur? That's going to be the medial circumflex femoral artery and the lateral circumflex femoral artery. Next, what can be found in the femoral sheath? Well, you're going to find the femoral artery and vein and lymphatics, but not the femoral nerve. Next, what can you ask the patient to do in order to dilate the femoral vein so that you may be able to puncture it easier? That's going to be a Valsalva maneuver. Next, which muscle is referred to as the Taylor's muscle? Because it flexes and laterally rotates the thigh as well as flexes and medially rotates the leg. That's going to be the sartorius muscle. All right, guys, we're almost done again. We have provided some images for you to label. Recalling these images in a time setting will help you to perform well on the practical part of the examination. So label the images and then we'll be finished. Thanks.